Yeah, Maharishi has joined.
Yes, sir.
Mercy joined with a different company.
Ah, change your background.
Mercy joined on
Good
behalf
evening,
of
everybody,
Sun Pharma.
and welcome to the panel discussion on the real-world feedback on use of Elobixibat in treatment of chronic constipation in adult patients. Our agenda for today will be introduction by me. I'm Dr. Pragati Srivastav, the medical advisor for Dr. Reddy's lab. Following which, we will have a context setting by Dr. Manu Tandon and a brief talk on the clinical trials on Elobixibat, the Indian and global perspective by Dr. Zahir Nab. We will have our panel discussion with Dr. Manu Tandon being the moderator and Dr. Zahir Nabi, Dr. Satyam Harshi, and Dr. Praveen Reddy as the panel. We will then have Dr. Manu Tandon giving us the concluding remarks. A little background about chronic constipation and Elobixibat. Chronic constipation significantly impacts the quality of life of many adults, with available treatment typically focusing on just a single mode of action. This often leaves a patient with unmet needs as these treatments may not provide comprehensive and holistic symptom relief. Elobixibat as a first-in-class bile acid transporter inhibitor stands out with its dual mechanism of action of both pro-motility and pro-secretory, offering a significant advancement in the treatment. This webinar and panel discussion will explore why Elobixibat represents a breakthrough in chronic constipation management backed by the clinical evidence that demonstrates not just its efficacy but also safety in improving the patient outcome. I now welcome our moderator for today, Dr. Manu Tandon. Sir is the consultant gastroenterologist at Asian Institute of Gastroenterology at Hyderabad. He has authored more than 275 publications and has been invited as a faculty in national and international conferences for the over last 25 years. Sir has been awarded lot of awards and has also been listed in Forbes India as a visionary expert. Dr. Manu, if I can ask you to kindly introduce our speakers and panelists for today.
Yeah. Thank you, Pragati, and I'd like to welcome all of you to this webinar, which is, as you heard Pragati say, on chronic constipation and a new molecule that we are going to discuss today in the management of chronic constipation. But first, so I'd like to thank you, Pragati, and the scientific advisors, as well as the scientific fund from Dr. Reddy's for arranging this seminar. My co-panelists, I wouldn't call them speaker and panelists. I am also a panelist. Zahir is the speaker. Zahir is a rising star on the Indian gastroenterology scene, not only Indian, international also. His list of achievements is too big to be read out in the short time that is here, but you will hear more and more about him in the next few years, maybe the next decade or so. And Zahir is going to give us the talk on Elobixibat, how it acts, and what are its advantages. I have two young gastroenterologists also from the Asian Institute of Gastroenterology, Dr. Praveen Reddy and Dr. Satya Maharishi. Both of them are rising stars, very well versed, good scientific knowledge, good research material, and you will hear them today as they come and discuss, as we discuss your questions as well as what I'm going to put forward to them at the end of Zahir's talk. So, with these few words about our panelists, I'd just like to say a few words on what we are talking about today. Now, chronic constipation, I'm not going into the definition. Constipation in India, primary or secondary. Secondary, a whole lot of causes from drugs, metabolic, and everything else. Primary, it could be a part of an IBS syndrome or it could be idiopathic. And the Bristol stool scale is what we know. 1 and 2 are definitely constipation. The other end, some argue that 3 should also be put as a part of constipation, and 4 too, that is according to the Indian data. But that's not what I'm here to talk about. What I want to tell you is, in India, constipation is slightly different from what Rome tells us. We are now using the Rome 4 criteria, which the fifth criteria I am not yet aware of, but I believe it is also come, which gives us the number of stools per week and all. But in India, more than constipation, it is incomplete evacuation along with abdominal bloating that is considered as constipation. And somehow Indians have got a fixation that unless they have a clear bowel, nothing will go right during the day. Very, very important when you are tackling them. It's a sensitive issue. If you tell them nothing will happen, they won't take it lightly. Maybe they'll switch over to a doctor. From you to another doctor who probably pays them a little more sympathy. So, constipation in India is a problem both in the body and in the mind. Now, for all of you who are not familiar with the mechanism, basically, very broadly speaking, we divide constipation into normal transit, slow transit, and a defecatory disorder where it's the pelvic floor which comes into play and fails to do its job properly. Satish Rao is from Hyderabad, by the way. We are all from Hyderabad. Has classified these defecatory disorders into four grades. We are not going to go into it. What you should know is normal transit, slow transit, and a defecatory problem. All are the mechanisms of constipation. Pragati has already told you we have drugs and drugs and drugs. They may vary from simple prokinetics to bulk formers to bulk forming agents to laxatives which promote motility and have osmotic action also to natural medicines. Many of you would have come across patients who say we are only relieved by that churn or this churn, nothing else works. So what it means to say is that we have many unmet needs in the drugs that are today available for the management of constipation, whatever the etiology. Of course, when it's secondary, you always direct your attention to the primary cause, but by and large, to any form of constipation. And constipation is not limited to gastroenterologists. It occurs across all specialties. And I'm sure that all of you who are on the webinar would have had patients who come to you daily with this same problem of not relieving themselves satisfactorily. So today what we are going to do, Zahir is going to talk to us about a new molecule, Elobixibat. I'm not going to talk about the mechanism, but he's here to do it for us. He is going to tell how it is placed in today's armamentarium in the management of chronic constipation or constipation in general. And after this talk, we'll request you to put your questions in the chat box. I will also ask a question, and all the three panelists, Zahir, Praveen, and Maharishi, are going to take up these questions and give answers which will clarify all our doubts. So, with these few words, Zahir, over to you. Request you to start your talk on
Sure,
Elobixibat.
sure. Thank you, sir. So without further delay, I'll start. Is my screen visible and are my slides visible?
Yes, now it's visible.
Right. So I'll make it full screen.
Yeah.
And so we'll be discussing about, we won't be discussing about general management of constipation. We'll be focusing on what's about this new molecule which is available and regarding its role in chronic constipation. So, to begin with, let's start with the mechanism of action. So, we heard from Pragati as well that the mechanism of action is dual for Elobixibat. The two mechanism of action is it not only increases colonic secretion, which is also the mechanism of action for some of the other medications which are available to us. For example, linaclotide or plinganatide, which is also recently available now in Indian market, but it also enhances colonic motility. And the main mechanism is by reducing the absorption of bile acids into the bloodstream. So the enterohepatic circulation, all of us know that how it acts. The bile acids released in the bile in the second part of duodenum. They are finally reabsorbed in terminal ileum, and this is what we call the enterohepatic circulation of bile acids. This is mainly to conserve bile acids. So what it does is that it inhibits the ileal bile acid transport in the ileum, which reduces bile acid absorption into the bloodstream. and this subsequently increases the colonic motility and colonic secretion as well. So this improves the spontaneous bowel movements by increasing the high amplitude propagated contractions in the colonic area. So this is regarding the action. And now coming to the evidence that we have regarding the use of Elobixibat for chronic constipation. So majority of the studies were initially conducted in Japan, because this was the country where the molecule was first approved, and is being used for the longest duration than any of the countries, whether it's West, and or if you consider India also, where it's has been released recently, the molecule is relatively new. So this is I'll say the landmark trial which paved the way for Elobixibat in the management of constipation. The initial was a short trial, including 69 patients, and subsequently it was converted to an open label long-term safety trial where it was evaluated for 1 year. So in the initial study, it was evaluated, prescribed for 2 weeks at a dose of 10 milligram per day, and was compared with placebo, and the change in spontaneous bowel movements was recorded. In the open label trial, it was given for 1 year, and 340 patients meeting room 3 criteria were studied, and different doses were evaluated: 5 milligram, 10 milligram, and 15 milligram. And now the main aim in the open label trial was safety and the severity of adverse events. So seeing both the studies, you can see that that patients who had their spontaneous bowel movement within 24 hours, 86% of the patients, and coming to complete small bowel movement, 46%, nearly half of the patients achieved a complete complete bowel movement within 24 hours. So this, which means that at least half of the patients had complete bowel movement, spontaneous bowel movement, and most of them, they had at least a bowel movement in within 24 hours. So coming to the bowel frequency and the bowel form, because this is also important. So if you see the Bristol stool chart, you'll find that type 4 is considered the type 3 and 4, they are considered the normal bowel forms. And if we see the efficacy of Elobixibat, it improved the consistency of bowels, and it was much better than placebo when it came to the form of bowels. The quality of life has been studied again. This is a Japanese quality of life scale where it improved the quality of life, because it is an important aspect when we talk about constipation, because constipation is associated with poor quality of life. So not only quality of life, but the patient satisfaction score were significantly improved as compared to baseline. So this is all what we are talking about, the landmark study which was published in Lancet in 2018. So coming to the safety in short-term and long-term use, the most common adverse events were abdominal pain and diarrhea. And minute abdominal pain is especially associated with Elobixibat. But the important point was that it was transient in most of the patients, and most of the patients, they don't require a reduction in dose to counter this problem. So 61% of the patients, both pain and diarrhea resolved without any reduction in dose. And in one-fourth of the patients, some dose reduction. For example, if you are starting by in a typical dose of 10 milligram per day, then you need to reduce dose in 1 out of 4 patients, so that the diarrhea or pain will subside. There were no major adverse events. And the best part about this molecule as compared to many other molecules is that it's not absorbed in the body. So which means that it typically acts like some of the drugs that we know, for example, rifaximin, which is not much absorbed in the body. Cholestyramine is another reason which is not absorbed in the body. So they are not associated with major adverse events because they are not systemically absorbed. So you can see that the excretion in urine is minimal. There is practically no excretion, which means it's not absorbed. So it acts locally it's not absorbed in the circulation, and that is the reason that safety wise it is one of the safest drug for chronic constipation available in Indian market. What about the data in Indian patients? We often say that the molecules, the constipation type is different in West as well as in as compared to Indian patients. Their perception is different. Their form of stools, their fiber intake is different. So, what about the data in Indian patients? So, this is this is the data in Indian patients. It's not available online, but this is the experience in Indian patients. It improved the weekly spontaneous bowel movements as compared to placebo, and it also increased the complete spontaneous bowel movements as compared to placebo. So, what about the safety issues, and what about the response within 24 hours? So, the best part is that a lot many patients can get their first spontaneous bowel movement within 24 hours. Now, why it is important? The importance is that once the patient gets response, then the patient can also use this medicine on an SOS basis, because the response period is very short. For example, if the patient responds well, but on and off he faces constipation, he can take intermittently use Elobixibat to get a response, because the response period is quite short. So the safety in Indian patients, if we see that most of them they did not have any severe adverse events. Again, if you see this adverse event graph, you'll note that abdominal pain is one of the adverse events that is often noted with Elobixibat, but it often resolves without any further modification in doses. But if the patient has pain as a predominant complaint before, then probably you need to think whether you want to give Elobixibat or any other drug. So this is one of the key features that you should keep in mind while you are prescribing Elobixibat in your patients. Diarrhea was not found to be a predominant complaint as with many other laxatives or secretagogues in this category, and therefore these patients they respond well without diarrhea being a predominant effect. Now, coming to different patient populations, for example, elderly patients, again, Elobixibat was found to be quite useful without any significant increase in adverse events as compared to young patients. So this is again a data which is recently published in BMJ, and you'll find that patients who are more than 65 or 75 years of age, safety and efficacy was well demonstrated, and had improved rectal sensation. Now, rectal sensation is something which gets diminished with chronic constipation, and therefore, if the patient is if the rectal sensation improves, then in general the constipation severity will reduce with time. Now, what about patients with other comorbidities? As we already discussed, that it's minimally absorbed in the body, and so practically there is no systemic absorption, and that is one of the main reasons that it is safe in patients across major comorbidities. For example, diabetes, renal disease, there's no problem. In patients with heart failure, it has been studied. In patients with malignancies of different organs, and in those with Parkinson's disease. So these are different categories been studied and found to be useful without any major side effect, because it does not interact with other drugs, it's not systemically absorbed, and that is one of the reasons why it is one of the safest laxatives in its category. What about if the patient is on some laxatives and he's not able to wean off that laxatives, especially stimulant laxatives, because they have often been blamed for habit formation. But there is some data to suggest that once the patient starts Elobixibat, at least half of these patients can wean off from those stimulant laxatives. So this is another positive point, that you can add Elobixibat and gradually wean off the patient of its previous laxatives, which are often not recommended for prolonged duration, like stimulant laxatives. What about its problems with the dose escalation? For example, the patient does not respond to a 10 milligram per day dose. You can escalate the dose to 15 milligram. In fact, some studies also suggest that up to 20 milligram per day is also a safe dose for Elobixibat, and there is no gross change in the incidence of adverse events, which means that dose escalation does not necessarily increase the rate of adverse events when you use Elobixibat. So this is again a safety data for and efficacy data of different doses. If you see that the effect of Elobixibat, the good effect of Elobixibat increases from 5 to 10 milligram, but 10 to 15 milligram, there is no significant difference. So most of the patients, they are likely to respond to a 10 milligram per day dose, but some patients, if they don't improve by 10 milligram, you can further increase the dose to 15 milligram. And again, the point that we discussed, that the rate of first spontaneous bowel movement within 24 to 48 hours. So 90% of the patients, they get their first spontaneous bowel movement within first 24 to 48 hours, which means that this drug is not only effective, but it is very rapidly effective. The patients are going to respond within a day or two. Additional information about Elobixibat. The other beneficial aspects of Elobixibat is its favorable impact on glucose and lipid metabolism. So now there is sufficient data to suggest that not only the glycosylated hemoglobin, that is HbA1c, improves from 0.2% to 0.8% in some studies, but also the LDL cholesterol reduces without a negative impact on HDL cholesterol, which means that it has a favorable impact on lipid metabolism as well. So if we are, if a patient with metabolic associated liver disease comes to you and you have to choose with that patient, particular patient, I think Elobixibat is a good drug because it improves the lipid metabolism. Whether that translates to improvement in fatty liver is not well known, but definitely it has a positive impact in patients who have abnormal lipid metabolism and they have some sort of dyslipidemia, where Elobixibat can be a better drug. So what about its comparison with other treatment modalities? For example, bisacodyl, prucalopride, and linaclotide. The majority of the data which is available right now, it suggests that it might be more effective than prucalopride and similarly as effective as bisacodyl and linaclotide. The problem with bisacodyl is it's not recommended to be used for long term, and therefore Elobixibat can be a useful alternative where it's similarly effective to bisacodyl. What about the number needed to treat? This is again one of the features that we use to decide whether the patient should be treated, whether this drug is effective or not. And if you see, the number needed to treat with Elobixibat is 3, which is a very good number if you consider the efficacy of this drug. Now, as compared to some of the other drugs, for example, prucalopride, the number needed to treat is 6, which is much higher as compared to Elobixibat, which again suggests that Elobixibat, probably there is no head-to-head trial, but probably Elobixibat may be more effective as compared to prucalopride. The incidence of diarrhea as compared to other laxatives is less with Elobixibat, and this is one of the favorable points regarding the use of Elobixibat, because the most common when you start using any laxative is that the constipation turns into diarrhea, and then that's a separate problem. So this is again a favorable point regarding the use of Elobixibat. Regarding the drug interactions, many of the drugs are systemically absorbed, and that is one of the reasons that there are some drug-to-drug interactions, but Elobixibat has minimum systemic absorption, and that is one of the reasons that the drug interactions are less, and the onset of action is more rapid as compared to most of the laxatives which are currently available to Indian market. So this is finally the summary slide, that what are the options available to us and what are the safety profiles and the patient profiles where we can use Elobixibat. The only negative point that has been raised about Elobixibat is that patients who have pain as a predominant complaint along with constipation, probably Elobixibat, you should reconsider using it, whether you should use it or not. But if the patient is having pain due to constipation, that pain is going to resolve. But then again, pain abdomen is probably one of the features which limits the use of Elobixibat in patients who come to you with pain and constipation both. Otherwise, for majority of the other features, if you say it's safety profile in elderly, in diabetic patients, cardiac patients, and renal patients, Elobixibat, there's no problem while you use Elobixibat in these patients. So that's all from my side. We'll be happy to discuss if there are any further questions.
Thank you, Zahir. That was a nice summary. You introduce us to a new compound mode of action. Well, before the questions come from our viewers and people who are joined us online, I'd like to put in a few questions to all of you. Some of them is a repetition of what you have told, but I'll begin with Maharishi. You are there.
Yes, sir.
Now, this drug has come recently. We all know that.
Yes, sir.
Which patient profile do you start this drug with?
Sir, patients with elderly patients who had this chronic idiopathic constipation, already they were on the polypharmacy with multiple laxatives. They tried many medications. Despite this, also they are not passing. They are not having spontaneous bowel movements, which are less than 3 per week. I consider in this elderly patients, sir. And also, we often see with patients with comorbidities, sir, like with elderly patients with comorbidities, with diabetes, they might have slow transit also. So, as this drug has both mechanism of action like increased motility and secretion, so I consider in these patients, sir.
Okay. Zahir, you have
Patients with
already
chronic
told
idiopathic
us.
constipation and then
Ah,
slow transit.
okay. Zahir, you have already told us that it is barely absorbed, so no side effects, and how it is useful in comorbid conditions. Now, all of us, nearly all our patients who are above a certain age are comorbid. So, where do you place this drug? Suppose a multi comorbid patient comes, heart, kidney, sugar, everything put together. Would you take it as the first line or would you add it with something else?
I think it can be considered as a first line drug in these patients because there is no brain involved regarding drug to drug interaction and whether this drug is safe in cardiac patients, renal patients, and whether there is in fact it has been shown to be safe in hemodialysis patients as well. So because of almost zero absorption and it acts locally, so I think it can be started. The cost is not a major issue. I think this, if we see the cost, also compare the cost to other laxatives, it's at par with the, in fact, even cheaper than many other laxatives which are
Yes,
available
yes.
in the Indian market.
To my knowledge, 5 milligram is 22 rupees. So it will be about 44 rupees for the 10 milligram dose. So you say that if you have someone coming to you with a lot of comorbidities, we straight away can start it.
We can start it.
Praveen, now
Yes,
you've got patients coming with all these profiles.
yes,
Do
sir.
you think Elobixibat will have the same action across the spectrum, or it will act better in some profiles and not act better in some profiles?
Actually, I started this as an add-on therapy in
Okay.
patients who are not satisfactory with other groups of drugs like cosmetic laxatives and all.
Ah,
So once I initiated these drugs, few patients came back to my OPD after a month of experience, and then
yes.
their spontaneous bowel movements improved. So I stopped the other drug and just continued with this. I didn't find
So
the dose.
you initially started his
Then,
add-on and then
then
slowly tapered off the other drugs. Very important message. Zahir did mention it where it was used, but any of our audiences who's listening, comorbid patients, absolute safety profile, not absorbed in the body, and what you heard Praveen's personal experience. I think it's too short a time in India for us to get papers of our own. But what he rightly says that when the response came, he withdrew the other drugs.
we had
Thanks,
only
Praveen.
experience.
Maharishi,
Sir,
any advice would you like to give regarding the timing of giving this drug? Very important instruction for practical purposes.
yes, sir. Because this drug needs time to act. So ideally, it is recommended to take before a meal, sir. So ideally, at least 90 minutes before the meal, this drug should be taken. So it acts efficiently at that ileal bile acid transporter site. So one
Okay.
study by Nakajima, this in the Japan study, they have told that they studied in both three patients, sir, like before breakfast, before dinner, and before lunch. But
Yeah.
they have seen significant improvement in patients who has taken before breakfast and before dinner.
Okay.
And when they compared to before breakfast and before dinner, before breakfast who has taken, they had much more spontaneous bowel movements compared to the dinner. Although the reason was not clear, might be they
Okay.
were pertaining to that, like during night the gastrointestinal motility will be low.
Okay. So you say that first thing in the morning is the best option
Best
before
option.
you do anything.
Yes.
Excellent. So another important point, please. These are all practical points to get you your maximum effect with Elobixibat. You heard Maharishi say any meal 90 minutes, but best in the study that was done in Japan. Most of the studies have been done in Japan. That before breakfast is the best. Zahir, you start with 10 or mostly, or you start with 15, or you start with 5 percentage wise? What do you use dose wise? This is again a practical point to all the people who are following us on this webinar.
I start at with the 10 milligram per day dose, sir, and
Yeah. And how
depending on
many
the
do you think you needed to start with? 15, or you never started with 15?
almost never started with 15, because here the mechanism of action is different, and there are two ways in which it's effective. So most of the patients, in fact, I had to titrate the dose down in say 20 to 30% of patients, because with even 10 milligram dose they had some of the
Extra
patients
bowel
had diarrhea.
movements.
So increased bowel movement. So titrating down was more than titrating up. So
Oh,
most of the patients I have to titrate down. One is because they are having good bowel movements, and second is the reason that that most of the patients, they don't require a 15 milligram per day dose.
okay. So you heard that also. Indian weight, Indian habitat, our constipation, Zahir has pointed out, I pointed out, is totally different from what is described in the Rome criteria. We have, a different look at constipation. And Zahir says that most of the time, 10 or even 5 is good enough. But of course, literature says that if someone is resistant, you can step up to 15. Praveen, you have told this already. You used it as you used it first as an adjunct with other drugs, but now you know that it's doing well because you have withdrawn the other drugs.
Yes, sir.
Now, in your patients, do you think in the future you can start it as a monotherapy
Yes,
and hopefully get a good response?
yes, sir. Definitely in patients with particularly elderly patient with comorbidities and patients with chronic constipation. So we can definitely start it as a monotherapy because of less side effect and
Correct.
more favorable profiles, as well as cost when compared with the plecanatide and all. It is almost one fourth of the cost, sir. So I think
Correct.
we can definitely.
I fully agree with you. Some of the drugs are phenomenally costly, and I say I'd rather have constipation than pay for the drug. That costly they are. So you heard Praveen say, since the drug is not absorbed, no toxicity. Zahir showed us 0.01% goes in the urine, the rest all in the fecal matter. So as a primary drug, especially elderly and comorbid, where you want no side effects, probably monotherapy and drug of choice now. And I would like actually your anyone in the audience who can give his own opinion on what is the effect of the patients that he has used on. Maharishi,
Sir,
now you saw Zahir's last two slides, all the summary of all various drugs. Now you have to consider dosage, convenience, cost, side effects. Where do you place best position for Elobixibat? You see the cost, you see the side effects, you see the everything, comorbidities, you see everything, and then tell me, let's say 6 months from now, where will you start using it in your practice?
think considering all this cost, dosage, convenience, safety profile, and efficacy wise, I think in comorbid patients, we can start it as a monotherapy, sir. Or
Okay.
like if patients are already on multiple drugs, few patients might not be like ready to take off the laxative. We can add on as a add-on therapy also, sir. We can continue with this polyethylene glycol laxatives, and we can add on this drug who are still not getting the spontaneous bowel movements. And cost-wise, compared to other drugs, it was definitely low, because other drugs like plecanatide are very costly. And compared to safety wise, it's very minimally observed, less than 0.01% in the urine. And CKD patients also we can give easily, sir, this drug compared to prucalopride, which requires renal monitoring. And one more is neurological or this cardiac patients, because as it is improves not only the spontaneous bowel movement, this Elobixibat improves the straining, and also it also improves the straining, sir, and increases the defecation desire. So in the cardiac patients, we hardly tell them not to strain. So when the drug is also improving the straining, I think we can consider in cardiac, diabetic, renal, all those comorbid patients. And
Okay, so the way Maharishi is saying, I feel in the next few months after he gets experienced a little more, he'll probably place it high up, especially in this special subsect of the population that he has just mentioned. Zahir, same question to you. I just want to add, you said that lipids, sugar, and also are added. Do you think that's just nominal, or it's clinically significant also?
So the
Same
difference was.
question, where will you place it, and this side, this side benefit, or whatever you want to call it, secondary benefit?
So let's talk about the three main second line drugs, sir. There are three main second line drugs. One is lubiprostone, that is very commonly used. Second is prucalopride, and third Elobixibat. And let's say fourth one is plecanatide. Now the question is, there are all second line drugs which we usually use after the first lines fail. So there are, if we see their main adverse event, for example, with the Elobixibat, it's pain, abdominal pain. That's its main problem. And the pain is, with every drug that increases the motility, pain is one of the predominant problems. But then if we go to this lubiprostone, the main problem is nausea. So I'll prefer this drug, Elobixibat, in patients who also say that they have nausea, because most of the patients, they have not one simply constipation, they have one or the other trouble also. So if they have nausea, Elobixibat is my choice. But if they have pain, also one of the predominant complaints, I'll go for something other than Elobixibat. Now the third drug is, for example, plecanatide. Its main problem is diarrhea. Elobixibat, the diarrhea is less of a concern, pain is more of a concern. So I'll choose the other drugs and not this plecanatide as compared. So all depends on what are their main problems, their main adverse event profile. And if the patient is already having that symptom, I will choose the other drug as compared to this drug.
So you say we should customize our management individualize our management
Yes.
depending on the
Yeah.
symptom profile, along with
Right.
constipation. For pain, something; for something
And in
else.
future, I guess, yes. Fecal bile acids will tell us that 30% of the patients who have this low fecal bile, I think they are the patients in future where we can specifically straight away write the first line drug as Elobixibat, because
Correct.
that will be the most favorable patient population.
Praveen, summing up, same question to you, and summing up, anything more you would like to add in all this that Zahir has told you, Maharishi and Zahir have answered, and I may summarize at the end. So anything you'd like to add from your experience with Elobixibat before we close from our side and take up questions
Yes,
from the audience?
regarding the timing of the medication, I started them to take the medication in the morning, like before breakfast. But
Yes.
them are not happy with that. They have PPIs because of other comorbidities and all, and they are already having hypothyroidism. They are taking those medications, and some people they are not convenient to use these restrooms at their workplace and all. So they themselves change the medication they want it to take during the night, so that the timing can be
Yeah.
flexible.
And the response was similar, or the response dropped or something? No,
I
similar
got
response.
similar response. I got feedback from only a few patients, sir, whom
Okay.
I seen. In them, the response was similar only, sir.
Okay. So let me just summarize what is the gist. It's a new molecule. It acts by inhibiting the bile acid absorption, and bile acids, as you know, both osmotic and motility, they help. Its biggest plus point is it is not absorbed. Zahir pointed out rifaximin, another commonly used drug for gut disorders, cholestyramine, fine, rifaximin. So no side effects at all. Widely used in all comorbid conditions because of its safety profile. The adverse effects are minimal. Maharishi has told us the best taken 90 minutes before eating, ideally in the morning, but Praveen has just pointed out sometimes logistics do not allow them to take it in the morning. You can give it at night because the second best, according to Maharishi, what he quoted the Japanese study, was before dinner. So, if not in the morning, someone best before night. If someone is on a night shift, he can take it in the morning. The other thing is the dosage is 10 or 5, but if there are resistant cases, you can go to 15. You can mix and match it with the other drugs, slowly taper off. You heard that Praveen also comment on that in a couple of months or maybe a couple of weeks later, he's totally started tapering the other drugs off. The safety profile from the study that I have seen is as long use as 5 years, 4.5 years. There is absolutely no significant adverse effects. Zahir pointed out a few very minor side effects, and I think that is less side effects, low cost, good efficacy, easy once a day dosage, all should go to make it a good drug to use in cases of constipation. Should specifically suit our population because we are the diabetic capital of the world and we have many comorbidities amongst our patients. So it should be helping all of them. So with this summarization, I'd now leave it open to you. You should now tell us, Pragati, whether any questions our panelists need to take up. I can pass it on, or you can read it to them.
Sure, sir. I'll just put up the question. We have got a few questions from our audience. So one of the question is, are there any specific contraindications that needs to be kept in mind while we are prescribing Vixibat? Sorry, Elobixibat?
Zahir, any
Yes.
contraindication
So,
absolute?
so absolute contraindications, like for any pro-motility agent, is bowel obstruction. If there is anything to suggest that there is bowel obstruction, no pro-motility agent should be given, like Elobixibat is one of them. Second is hypersensitivity, which is common. So no major things to contraindicate its prescription, but these are two scenarios where I won't be using Elobixibat.
One more question is that because the drug works on the bile acids, so is there any meal preference that is to be taken before the drug is to be given? If you can just put some points in
The
that.
best is in the morning because that is when your body is preparing to pour out bile acids, and because it's locally acting, so it's best that both the bile acids and the drug reaches the ileum at the same time, so that it can block its absorption locally. So best is before breakfast, as Maharshi also told. And if the patient is having, because the first spontaneous bowel movement can be as early as 6 to 9 hours, so that thing has to be conveyed to the patient that you may get the bowel movement on the same day, maybe in the evening. If he's not having any access to loo, he can wear a diaper.
Yeah. So it can be customized based on the patient's preference
Yes,
also.
yes.
And the meal, what kind of meal should be usually taken by these patients? Because again, high fiber or high fat is not, high fat will not be a consideration that the doctor will give to a patient. So how exactly should we tell the patient what kind of meal, what kind
So
of hearty meal should they take before the drug?
Right, right. So I think he can have a normal fat diet. The diet should not be having excess fats. But having said that, whatever studies they say that its absorption is much reduced by a fatty meal. Practically, absorption has nothing to do with its activity because it acts locally. So I think there's not much to suggest that diet is going to affect things.
Yeah, even I agree, Pragati. I don't think they have to change their meals much. It's a locally acting drug. It will move down near the terminal ileum and start its action. That's all.
So many a times what usually happens nowadays, it's like a norm that light dinner has to be taken. So
Well,
will
that's
that be causing an effect is what exactly the question is. So it's a
good.
very
Yeah,
Marishi,
yeah, it's a very
you answer
valid
the dinner.
question.
You answer this. Do we advise a light dinner? Light dinner as such is good for health. So we should follow. But
Yes.
will it affect the drug or it will not affect?
No,
so
sir,
it
I think
yes sir. Please.
I don't
Right?
think that there no point in changing in a pattern of diet. They can continue the same.
Theoretically, there may be do's and don'ts, but practically speaking, in my experience, it has not so far been a concern. Like a patient has taken a normal dinner, heavy dinner, light dinner, it has not. The only thing is that again, the best time is still because the landmark study again they gave before breakfast only. Right? Now,
Yes
when
sir.
it comes to practice, this has to be seen that if the patient passes that spontaneous bowel movement in the evening. So that is a practical concern. Then, as Maharshi told, can be taken before dinner also.
One more question is in IBSC, where the consideration is to tackle both pain and constipation. Which one would you prefer in such patients? Which drug would you prefer? Do you think Elobixibat has a role to play in these patients?
I think so because IBS constipation, the norm is that once they pass free bowels, their pain is reduced, right? So if his pain is not coming down, I'll change from Elobixibat to some other drug. But if the pain improves, the pain was mainly due to constipation. I think Elobixibat has a lot of role to play.
Dr. Tanda, would you like to give your views also on this? The use
Yes,
in
I
IBS.
think I have the molecule is a novelly acting molecule. So far, we have had prokinetics, laxatives which produce through osmosis, bulk and all. This is a new mode of action. We have just started using it, Pragati. It will probably you will have to give us our own experience. Now we are reading literature, Japan mostly because they are the ones who did. FDA is yet to go through this. Uh, India, we have just started. I think 3 months later, probably we'll give our own experience in all situations combination, side effects, comorbidities, and average dose that we will use for the Indian build that we have got. So I feel this is a drug with promise. As far as our own experience, to be very honest, I cannot give you my personal experience because the follow up has been very small, minimum 3 to 6 months, and then we will form a concrete idea. So that's
Yes.
what I feel. But many advantages I listed out. Not very costly, in fact, very reasonable. Once a day dosage, no side effect, definitely efficacious, can be used in comorbid conditions. I think all the indications are there. It's up to us to learn after we use it real time in our patients, not
Yes.
books, real time.
Yes. So this whole panel discussion is based on your real world feedbacks only. And Dr. Praveen, have you used the drug in IBS-C patients? Because the trial that had been done, though it was not mentioned, but they had patients of IBS-C also in the trial. Though there was no analysis done for those patients, but they were included. So have you used them in your patients? You
Yes,
use the
I use them and I use in IBS constipation patients also. They already have that mild discomfort, but they complained of crampy abdominal pain, which got relieved with defecation. So that should not be a problem.
yeah. Thanks, sir.
I use.
Dr. Mershi, in your practice, how often do you see this pain abdomen and how important as a side effect it is for the patients?
We see pain
Is there
predominant
any
IBS. Often
discontinuation?
we see Indian patients, the perception of pain is different in the OPD. Few say as a discomfort, few say as a pain. It's different. Typically, pain predominant IBS, I think as of now, because the adverse drug reaction for the Elobixibat is only the abdominal pain, I might consider if there is a pain predominant IBS, I might not consider it as a first line drug in the Elobixibat. If IBSC has already, the Jay sir told, if IBSC, the pain is due to because of constipation, it might relieved after the constipation. After it passes the stool, the pain gets relieved. So the primary point of care should be to gets relieved of this bubble. So I can use in the IBSC patients. If it's only pain predominant IBS, I think I might think other drug initially.
How common is pain with just chronic idiopathic constipation, or if
I
the
think patients' pain, I don't think like they typically say as a pain. Most often they say as a discomfort,
Only difference.
bloating. They say most of
Hmm.
the patients with constipation will say bloating, discomfort, and distension symptoms actually.
fullness in
Yeah,
the
fullness is
abdomen?
anyway the Elobixibat improves the both straining and discomfort also. I think we can consider.
So one question is, how would you define the constipation? Like in Indian scenario, as you said, if you do not have a proper bowel movement in the morning, the whole day is gone.
Gone.
So, what would you how would you say to your patient that what is constipation? Because in India we have somewhere around, I think, 30 to 35% of the patients who come with self-perceived constipation, which may or
Yes.
may not be. So, what would be the advice that you can give the patients also from your point of view regarding this?
First, listen to them.
Mhm.
First, listen. Don't brush them off. I know it's tough. Sometimes with 30 people standing outside your door, you know this is functional and it's more incomplete evacuation. First, listen to them, give them a drug, maybe even a placebo which he has not used previously, and then I think tests and all I'm not going into. Reassure him that in case you don't pass satisfactorily on Monday, nothing will happen to you, nothing. I think that is my approach. Tests, of course, will be done sometime. In fact, at our center, since it's tertiary, most of them have gone and they look forward to finishing some tests, but that leave aside. Listen, give them a drug, and then reassure them. You know that giving a drug is as important in Indian mentality as just saying you don't need anything.
Yes. Dr. Zahir, we had like you had a slide on the changes in cholesterol and HbA1c.
Look,
Could you throw a light on how exactly would that be helpful and how exactly Elobixibat will be, acting for that to happen?
Yeah,
Your
so it's all about enterohepatic circulations. Once your bile acids are not absorbed, the liver is stimulated to create more bile acids, which means that how bile acids are produced, the basic mechanism is the liver takes up cholesterol, converts them to bile acids, and finally secretes them. So that is one of the mechanisms how it reduces the LDL cholesterol, and the ratio of LDL to HDL changes significantly when you are using Elobixibat. Now that may be an added advantage. That's not the main reason why we are using Elobixibat. There are drugs for reducing LDL cholesterol and managing diabetes, but that added advantage I think may be considered while we are prescribing drug, because India the patients with NASH and patients with dyslipidemia, patients with diabetes, it's on rise, and that maybe that slight advantage I think that can be taken into consideration while you are managing constipation in this group of patients.
Thank you. Maybe considering the time, I will just put across an open comment on.
I think we have lost Pragati.
Am I audible?
Yes, yes.
Yes, you. There was. I had lost you for 1 minute.
Oh,
Okay,
there
go
might have
ahead.
been some lag. So, sir, because considering the time that we have now, so I would just put out the question if you can one by one give us your feedback in the how it has been working in your practice. I think Dr. Tandon has already given us a good feedback on how it has been in his practice. So if Dr. Maharshi, Dr. Zahir, and Dr. Praveen can also said, and then Dr. Manu, if you can just conclude, then
Okay.
maybe we can finish. Dr. Maharshi, what has been your how would you uh, like put it across to the audience about how this drug has been in your practice?
So I think for everyone, patients with multiple comorbidities, constipation, elderly, so already on polypharmacy, multiple laxatives. Despite this, there are no spontaneous bowel movements. Patients are I think we can consider Elobixibat. Initially, consider as an add-on therapy. Then slowly you can make it as a monotherapy. Start ideally as 5 to 10 mg, as most of the studies have shown at 10 mg, not maximum 15 mg. We can titrate as per the dose. If patient is complaining of any abdominal pain or diarrhea, you can decrease the dose. Or like if you want to increase the bowel movements, you can increase the dose. And I think only concerns here in the safety wise, only I think which were not studied much. Decompensated liver disease, mostly in the severe liver disease, the studies were not shown how safe the drug was. And one more, I think I want to raise a concern here is not much studies, because as the drug decreases the liver bile acid pool, it increasing the prolithogenic bile state actually. When there is a decreased bile acid pool, we are creating the prolithogenic bile state. Whether we can prescribe the drugs in the gallstone patients. If already patient is having gallstones with chronic idiopathic constipation, whether we can prescribe Elobixibat or not, I think the more research should come into this actually. Because we are creating the prolithogenic bile state, how significant it is, yeah, after studying. That is the point.
Thank you, sir. Dr. Praveen, your views on Elobixibat in your practice.
Yeah, so far it's good, and we need more experience to comment upon the concrete statements on this. And exposing more exposure of bile acids to the colon, we don't know what is its role in the colon carcinogenesis in the long term. That even we need to study in Indian scenario. That point is to be seen. But the response is good and side effects are low because it is not absorbed. That is a beneficial effect of this molecule. So we are awaiting more experience and more response from the patients.
Thank you, sir. Dr. Zahid.
Yes, I think the same. I think we need more time before we can definitely recommend the other gastroenterologists. I think everybody has started experiencing Elobixibat at the same time. They have started prescribing at the same time. So all of us, we don't have that ample experience. Whatever experience we have is from the studies that we have published and limited pool of patients that we all have that combined pool. So far, the drug looks promising. Let's see in future if the efficacy is maintained and the pain which has been said as a setback for the drug, whether it's a real problem in Indian patients, we still need to know it.
So, Dr. Kannan, concluding remarks from your side.
Yeah, you will of course be thanking us, but I'd also like to thank. Let's start with you only, you and your entire team, and DRL, Dr. Reddy's, for helping us learn about this drug as well as talk about it. I'd like to thank Zahir for giving a very clear, lucid presentation on the mode of action, efficacy, and side effects, and both Maharishi and Praveen for answering the questions that I and you means the people who were listening put forward, as well as their own opinions. So, all in all, since it's a drug which is relatively new, as all of us have started, it's been a learning experience, at least for me, and I'm sure that we'll be able to give you more concrete answers maybe 5 to 6 months from now. So thank you very much. Thank you, Zahir, and the speakers, and your entire team, Pragati.
Thank you so much, and thank you to all our panelists for joining us on a weekday, and also to the audience who are listening to us on a late evening on a weekday. Thank you so much for joining us. Looking forward to maybe having some more panel discussions in the future with you. Thank you so
Right.
much.
Thank you. Thank you.
Thank you.
Okay. Take care.
Okay, good
Bye
night,
bye.
everybody.